Good morning. My name is Fabrizio Calliada. I am full professor of radiology at University of Pavia and chief of the residency school of radiology in the same university. Formerly, I was the director of the radiology department of Policlinico San Matteo, and now I am opening a new ultrasound unit in the Casimiro Mondino Neurological Foundation, also in Pavia. Normal interest that was contrast-lateral ultrasound and Doppler. Now I'm moving to a neurological direction, to the examination with ultrasound of peripheral nerves, both in trauma and degenerative disorders. And we try to do that by diagnosis and also by interventional to try to understand how to repair something. In my normal life, I'm also vice president of the Italian Society of Radiology and general secretary of the Italian Society of Ultrasound.
The talk of today is about color Doppler of the renal artery stenosis, diagnosis, metered, scans, tips and tricks. And we just cost and benefits about Coronal Doppler ultrasound. Probably they are good, but not really very good. So the benefits are low cost, good sensitivity and specificity, but only in experience. It's not invasive, it's repeatable over time, so it's ideal in follow-up. As a cost, the diffusion of the metallic is only relative. You can find in some place, but not everywhere. The exam should have a long duration, but long, very long, is the training of the operator. So, very good, but not completely good, the cost-benefit ratio. Doppler diagnosis, how we do the diagnosis of renal artery stenosis. We have direct sign and indirect sign. For the direct sign, we have a focal color aliasing. We have a color bruit, the presence of small pixel of every kind of color and direction all around the vessel. And this is a sign of turbulence. The velocity should be more than 1 meter 80 centimeter per second. We can approach also a renal artery ratio, R, more than 3.5. I really don't use so much, but anyway, it's described in literature, so we need to mention. And we can look at the significant stenosis, so from 50 to 85 diameter reduction with a sensitivity that is variable between 89 to 91, and the specificity that is variable between 73 to 97 in the literature. Indirect sign, we have the increase of the time to maximum velocity more than 0.07 second, and the velocity of rising more than 3 meters per second, and we have differences in resistance index more between the two different left and right, more than 5%. We can judge in this way only the severe stenosis, so more than 85 diameter reduction. This is evident in an old work of Michel Fortuny that is making experimental work, but the sensitivity is only 25%, so very, very low, and the specificity is very high. So we can be sure that we encounter this kind of sign. This is related to a severe stenosis, but severe stenosis should be there, and you cannot see any one of these indirect signs. But okay, now we talk about direct sign. Peak systolic velocity more than 1.8 meters per second. Post-stenotic turbulence, RAR more than 3.5. Pro, detection of stenosis more than only 50%, and anatomical identification of the site of stenosis. So we look and we see the presence of stenosis versus length of the exam time, the operator training, as we told, difficult evaluation of supranumerary arteries. Okay, now we look at the aliasing in one of these renal arteries. You see the two renal arteries on right, but only one has stenosis. And if we measure there, we see a velocity of 2 meter point 24. So we are sure that is a stenosis significantly, and we have a resistance index of 60%. And this is important. Why we look at resistance index? Because we have a very old but absolutely important work for Rademacher in the New England Journal of Medicine 2001 that say that if we have a resistance index more than 80%, it's better to don't dilate, because in those patients probably we will observe a renal insufficiency in some months. So the idea is the resistance index is correlated to the possibility of making a dilatation and stenting of the artery. So we need to look to the resistance index, otherwise we are the possibility we risk to go dilatation, make dilatation and stenting in patients that will not improve but make worse after the dilatation. So look at other example. In this case, we have aliasing, but we have also this bruit over. And this bruit is important because we know that when it's present, it's probably because there is a stenosis. We increase, in this case, the sensitivity. We look better and we see there is a stenosis with a velocity over 200, and the resistance index is 70%. So the indication of a dilatation is good, but we are at limit in this case. Another case, we have aliasing and a very important bruit. So there is turbulence here. We increase the velocity, we see from 39 to 89, just to look at the presence of the synoptic tract. And we measure here, we have a velocity more than 200, and we see that the resistance index is over 80. So in this case, surely we don't have the possibility to make a dilatation, because the patient will have will lose the use of the kidney, and we don't have any benefits of dilating. Another example here, you see the presence of aliasing here. We measure and we see peak systolic velocity 193 with the resistance index over 80. So even in this case, probably there is not the indication of make dilatation. Another case, aliasing. Here, right artery, we look here, and we have over velocity, over 200, and no indication of any dilatation, because the resistance index in the kidney is 100%. So no benefit for the patient to make any dilatation. Of course, we have another case, another cause of stenosis that is more frequently in young patients, fibromuscular dysplasia. In this case, we have no parallelism of the wall of the renal artery, and is described this moniliform aspect of the artery. You see, this is large, this is stenotic, this is large, this is stenotic. And in this case, we measure an increase in velocity to over 2 meters per second in the presence of lesion, of course. Another case, moniliform aspect, successive stenosis, and this is the angiogram, and this is the velocity that is more than 200. Renal aortic ratio. As I told, I don't use it much time because I think there is a difference in angle. Anyway, you have 62 centimeters per second here, 2 meter point 65 from here. So RAR is 4.2, so it's surely positive, and we found here a stenosis at the onset of the left renal artery. So we are looking to do the direct sign, now the indirect sign, and acceleration index altered. Early systolic peak disappears. The early systolic peak is this one, and resistance index reduction on the site of the stenosis. But really, what is? This is a normal situation with an early systolic peak, and the increase of systolic velocity, as you see, is almost right here. No reduction of time between the onset and the end of systolic peak. Here we have an index of rising that is increased. It's not the same as the obliquity here. And there is a Parvus Tardus sign. So we have a reduction of resistance, and the index here is very, very low. This kind of sign, Parvus Tardus, we borrowed from the presence in lower limbs arteries. Is present also in the kidney, but with a different percentage, because the kidney are not a terminal situation, because there are the arteries between the kidney and the capsule, and this made the kidney not a terminal territory as a lower limb heart. Anyway, these are the indirect signs, and we look some example. This is a very important example of Parvus Tardus sign. You see reduction of resistance and rise of the systolic. Systole is very, very long. Indirect signs are pro and versus. Pro, the examination is easy because you need only to look to the kidney, not to the artery. The operator training is very reduced. The identification of stenosis, you can guess the presence of stenosis even in supernumary arteries. You look at the upper pole, middle vein, lower pole, so you can guess the presence of the stenosis even in lower pole artery. Versus the detection of stenosis only over 80%. I remember the work of Lafortune about that. Impossible anatomical identification of the stenosis. You guess there is stenosis, but you don't see the stenosis. Uncertain sensitivity and specificity, and we see that the specificity is good, but sensitivity is very low. Now, some suggestion on how to perform the exam. And we start with the scanner. We need an ideal scanner. An ideal scanner is made by the presence of the coupling, imaging, and Doppler frequency, which means that I can use the higher frequency for B mode and lower frequency from Doppler, both color and spectral. And the Doppler frequency is better if it's low than 2 megahertz. Why that? Because it's a presence of Doppler physics. When I need to measure something that is very high velocity, but this high velocity is in the deep, I need to have a reduction of frequency, because otherwise I cannot measure. You can measure very high velocity when it's in a superficial way, mean carotid, but I cannot do the same on renal artery that is very low, very deep. Tissue harmonic is important. Variable radius convex probe is good because I reduce the work of the probe. Variable color pixel size is nice thing, is important, but not really fundamental. I think the first two are really mandatory. Otherwise, you cannot do every kind of examination. You can do sometime, but not every time. Now, why we don't need to use an anterior approach that is normally used by many? Because in this case, the presence of the stenosis that is normally at the onset of the artery is in a situation that is absolutely unfavorable as a Doppler sampling angle. So we can judge something that we really, when we really are at almost 90 degrees, so it's not feasible. We can have an oblique anterior approach with something better, but the Doppler sampling angle is often unfavorable. So I prefer personally a completely different approach with oblique coronal approach in right lateral decubitus this way. In this way, I see the vena cava here, and I see a small circle just under the vena cava, and if I move a little bit, I see that I use color, I see this presence of color here. This is the right renal artery. I make just a small moving of the probe and obtain this situation that is called banana peel view, because I have here the vena cava. This small circle here now is evident that is the right renal artery, but I see also the left renal artery just here. So this is the banana, and these are the peel, right and left renal artery. And of course, with color, this is the right one, this is the left one, going in a different direction. And I can also in this way look at the presence of aliasing and measure, in this case, not a significant stenosis. Here, the same thing on the left. And of course, if aliasing is there, I can measure and I can see the presence of the significant stenosis at 0 degree. So I'm sure that this measure is absolutely correct. Of course, we can do better with the motor scanner and see the aorta here, renal artery here, right, renal artery here, left, with this approach. And with this approach, it is also useful to look at supranumerary artery. In this case, 2 arteries. In this case, 3 arteries. And of course, also with color, 2 arteries on the right, 2 arteries on the left. This case, 3 arteries on the right, 1 artery on the left. And this is my maximum, with 3 arteries on the right and 3 arteries on the left. Of course. You can also use a different approach, making a 90 degree, making an axial view of the aorta, also on the same projection. And you see 1 renal artery here on the right and 2 renal arteries here on the left. And you can look also to anatomical variants in this very long renal artery, because you have a renal right kidney's ptosis, and so the artery is very, very long. And we can observe all the artery to the kidney. And also the presence, as in this case, of as you have seen before, the fibromuscular dysplasia, and we have seen just in this case we have a significant stenosis. We can make a possible axial approach, so we can have the aorta here, all the right renal artery here, and we look all the artery in the same view, also here, and okay, here, approach, aorta here, the origin of the renal artery, and all the renal artery to the kidney here. So I can control all the artery in the same view. Okay, but the presence of meteorism is a problem because we pass through the peritoneum and there is bowels, and if there is meteorism, this should impede this kind of approach. In this case, you just put the probe a little bit higher, a little bit on the flank of the patient, and we pass without or outside the peritoneum or almost outside of the peritoneum. Look, okay, this is both on the right and in the left approach. But, okay, the same thing. But the problem is that increase the distance between arteries and transducer, and it means that we need a low frequency Doppler probe. So both the anterior approach and the coronal approach are good, but if you try to use every time in every patient, this approach is almost perfect, but it's perfect if you have a low frequency Doppler, otherwise you cannot reach. In some case, even this situation is not good, and we can go a little further posterior, so we transpass completely outside the peritoneum from the liver and the kidney. In this case, unfortunately, the quality of B-mode is very, very low, but the quality of the artery and the Doppler is very, very good because you are almost at 0 degree. And in this case, you can look the presence of a small stenotic situation, not significant in the middle portion of the renal artery, right renal artery in this case. Of course, the distance is increased more, and you need more low frequency Doppler. With this kind of approaches, you can do a renal artery examination in every patient. I think I do this almost every day, and probably in 1 year, every 1-2 cases that renal artery examination, complete renal artery examination is impossible, but almost every patient is feasible with this kind of approach. And now, spectral Doppler signal detection. That is probably the most difficult portion of the exam. Why? Because it depends on equal parts on the operator's ability and on the patient compliance. Because many patients cannot suspend their respiration for a small amount of time. And if you ask them to please stop breathing, they think the good thing is to continue breathing in a more frequent way. So it's difficult to do. And the scanner used is never a limitation, but of course is correct use, yes, and we try to understand which is the correct use. Okay, the correct use is to choose a good Doppler window. In this case, you see we have a big window for B-mode and color, small window for Doppler, but we need to measure Doppler. So this is not the correct way. This is the correct way. We divide vertically the Doppler window in big for B-mode and color and big also for Doppler signal. This is the good way because we need to measure this. We don't need this. We need this only to understand where we are. But we need to measure this. And of course, in some cases, when it's very, very difficult, even a window made only for Doppler is good. Another good thing we need, and we'll explain this better later, when we measure the resident index, we put a caliper on the peak systolic and another caliper normally on the end systolic. But it's better to put the end systolic before the peak because the time between this and this is lower than this and this. And in patients that normally breathe as they want, if we don't lose so much time, it's better. But we have some example later. It's the same patient with different window. If I measure the peak systolic, the resident index is not correctly measured anyway, but we have a resident index of 60%. The same patient is 78%. So be careful. We can judge wrongly if we don't measure correctly. Another thing about Doppler signal, please, even if you have a good window this way, if we have a very high velocity here, this is not good. We can cover all the window with a Doppler signal because the best way to measure, don't measure with very low signal here, but measure please on a bigger signal where to look at the resistant index is easier with less possibility to be wrong. Another way, in this case, here and here. And the Doppler is very big and we can measure correctly. Why did? Because this normal patient, look at this, just one single systole-diastolic complex measurable because the patient is breathing and I have the chance to measure in only one possible. So I measure here because it's present, here because it's present. I cannot measure here. I cannot measure everywhere in any other portion of the signal because the presence is breathing and I have not a good systole-diastolic complex. So if I take one, the best thing is to measure here, otherwise I cannot have any possibility. I hope you like this presentation about renal artery. It's a little bit difficult Doppler application, but if you have a patient and you try to use the approach that I described, you surely will be able to have good results. Thank you very much for your attention.